This lesson is about skin and soft tissue infections. That is, the infections of the epidermis, dermis, hypodermis, the fascia, and the muscle and bone. How deep the infection goes, which layer is affected, will determine the presentation and the name of the diagnosis. What you do in clinical sciences is determine the next best step, that is the next best diagnostic test if necessary, or choose the right antibiotic. In clinical practice, you see an infection, you start an antibiotic, and if it gets better, all right. Most of the time, you don't have the information we're going to discuss in this lesson. And you can't usually see which layer of skin is involved because you don't biopsy skin infections, except for osteomyelitis. So what I want to do here is use the layer of skin advanced organizer we had from the first lesson to illustrate how and why each presentation has its presentation based on the layer that's infected, and get you start thinking about which organisms are the cause. And the skin infections are usually caused by the skin flora, staph and strap. So this is going to be our finder we're going to use with each diagnosis. The epidermis on top of the dermis, the subcutaneous fat, which is the hypodermis, a level of fascia under that, and then the bone attached to the muscle. And we'll see that depending on where the infection is, it'll get a certain name and it will behave a certain way on the surface. The two skin flora are Staph aureus and group A strep pyogenes. And I'm using this from our microbio. It's either group A strep or strep pyogenes, but because people use either when explaining them, I put them together to avoid confusion. These bacteria live on the surface. They're supposed to be there, but when they get below the stratum corneum, they get into the epidermis or below, they cause problems. They cause an infection. And because your job in clinical sciences is going to be to pick the right antibiotic, if you make the diagnosis of group A strep pyogenes, you will initiate either a beta-lactam or a cephalosporin. If you make the diagnosis of Staph aureus, you can start a second-generation cephalosporin, and if that doesn't work, indicative of MRSA, you'll need to use vancomycin. And what you're going to see is you're going to be able to link different infections with either of these organisms based on their behavior. Strep grows out. That is, it infects a given plane and moves within that plane, whereas staph goes down. You'll see staph causing osteomyelitis and abscesses. Strep doesn't cause bulla. Staph does. Those are going to be the tools you're going to use to decide which organism is it. First, you have to make the diagnosis based on the symptom presentation, which informs you which level of the skin is infected. Then you have to decide, is the strep or staph, to pick the right antibiotic. But because you're not going to have to choose the antibiotics at the basic science level, you just have to make the diagnosis and recognize the symptoms on the skin. We're going to correlate the layer of skin that's infected with the symptoms on top. And because these are all infections, rather than waste time saying there could be sepsis for all of them, because they're all infections, sepsis is dependent on the body's response to the infection. So all of these, being skin infections, may present with sepsis, which is an elevated temperature, elevated white blood cell count, elevated heart rate, and elevated respiratory rate. So rather than say this one can present with sepsis or fever, or I'm just going to say all of these can. The severity of sepsis, that is if they're hypotensive, responsive to fluids, etc., is going to determine things like the location of treatment, whether you can send them home, they need to be admitted, or they go to the ICU. And the severity of sepsis will also determine whether they get IV or PO antibiotics. Again, you're not making these decisions at the basic science level, so you don't have to worry about this. However, there is a general theme that the deeper the infection is, the more severe the sepsis. Now, of course, there are exceptions. A cellulitis may kill, whereas osteomyelitis may be completely asymptomatic. So I don't want you thinking that there's a strict correlation with the deeper it goes, the worse it is, but as you'll see, there's sort of a feel for that. So let's get started talking about our individual diagnoses. The first is impetigo. Impetigo is an infection of the very most superficial epidermis. The hypodermis goes unaffected, the fascia unaffected, and of course the skeletal muscle and bones below unaffected. It stays squarely above the basement membrane. Now, it used to be that impetigo was caused by group strep A pyogenes, period. The prevalence has increased so that it's about equal Staph aureus and group A strep pyogenes. But on a licensing exam, you're going to have to be able to tell the difference. So if you see just impetigo, you should assume that it's group A strep pyogenes. If the vignette wants you to know that it's Staph aureus, it cannot do it just by prevalence alone. So Staph aureus, which has exfoliatin toxin, causes bullous impetigo. So that if you see bullae and impetigo, it must be staph and it can't be strep. That's because only staph has exfoliatin. Exfoliatin targets desmoglein and causes a separation of the desmosomes of the keratinocyte layer, thus giving you the blister. Both of them are going to cause pustules, very tiny vesicles that are filled with pus. These pustules are going to occur on children, almost exclusively seen in kids on the exam, and on their face. These pustules will erupt, then coalesce and crust. The classic buzzword for this is honey-colored crust. Now, there's no way you're going to see honey-colored crust on the exam. That's a dead giveaway. But it's golden brown, and it's a crust where there was pustules. If impetigo caused by group A strep pyogenes goes untreated, you could end up with post-streptococcal glomerulonephritis. Now, of course, you can't get post-streptococcal glomerulonephritis if there's a staph infection. And unlike group A strep pyogenes pharyngitis, which can lead to both post-streptococcal glomerulonephritis and rheumatic heart disease, impetigo cannot lead to rheumatic heart. Moving a little deeper, we get to the next diagnosis, which is erysipelas. Erysipelas is an infection of the epidermis and the superficial dermis. The deeper layers go unaffected. It is an infection that includes the basement membrane and either side. This is one of those infections that spreads in the plane. The basement membrane separating the dermis and the epidermis, there's a fake space where the bacteria can get into, and it can easily spread in either directions. So that means, as a growing out sort of infection, the most likely candidate is group A strep pyogenes. Because it is spreading in the plane of the infection, it can grow very rapidly. So this is going to go from a normal skin to angry skin very fast. The lesion is going to be sharply demarcated. Normal skin clearly abutting an affected skin. And affected skin is going to be red, hot, and tender. That is because as the infection moves, it encounters affected tissue, because the infection is so close to the top of the skin, this skin is obviously red and the unaffected skin not at all. Now this is going to be important when we talk about cellulitis next. And the last thing I want you to know about erysipelas is that if it's on the face, it will not spare the nasolabial fold. If there's an erysipelas rash, you might have red cheeks and a red nose. That looks like a malar rash. Autoimmune disease, like lupus, causes a malar rash because of photosensitivity. The nasolabial fold is spared because sunlight can't get there. When the bacteria is under the epidermis, spreading across the skin, it doesn't care about the light, so it will not spare the nasolabial fold. And one infection layer down, we get cellulitis, which is an infection of the subcutaneous space. Some penetrating injury inoculates the fat underneath the dermis, inoculates the hypodermis, and the bacteria spreads in the plane of the infection. The fascia and the bones and muscles beneath are unaffected. Now, spreading in the plane of the fat sounds like a strep disease. So indeed, group A, strep pyogenes, is the default causative agent. But you can also have staph. And just like with impetigo, if they're going to give you Staph aureus cellulitis, they either have to give you a failure of the antibiotics used to treat group A strep pyogenes, or they need to give you evidence of bulla, because only Staph aureus has exfoliatin, which destroys desmoglein, which breaks the connections between keratinocytes, leading to the blisters. There must be some sort of inoculation, like a bite, any penetrating wound, down to the sub-Q space. Then the infection spreads out and stays within the sub-Q. The presentation is going to be an insidious version of erysipelas. Because the infection is way down here, it's far away from the surface of the skin, which means that you're not going to have such a well-demarcated redness. So it's not demarcated well. It takes several...